My topic for today is the antibiotic resistance as a global, and I think global rising problem for some citizens as we all here gather in Athens, some at home. This is the agenda of my presentation. First, the UTI as an abbreviation. This is the urinary tract infections, and we will use this abbreviation many times during my presentation. Then we will go through some statistics, some facts. We will talk about the reason and the risk of the multi-drug resistant pathogens, how to treat, how to react on this. We will speak a little bit about the resistant rates, antibiotic prophylaxis and urology, especially in pediatric endoscopic procedures. Then we will speak about where is the way to go to solve this problem about the rising resistance, and we will conclude with a few sentences, I hope. Statistics are more than 40% of women and at least more than 12% of men will have at least one UTI during their life, and up to 50% of those women will have the recurrence. About 80% of all UTIs is issued as cold. Uh, UTIs are becoming increasingly difficult to treat owing to the rapid spread of drug resistance among the gram-negative organisms, as we all know. These are the main organisms which are things which are responsible for the urinary tract infections. We can make this classification according to the risk, according to the source, and the clinical presentation of a level of severity of the psychiatrist, cystitis, death and infection of inflammation of the bladder, pyelonephritis, infection and inflammation of the renal pelvis, kidney, either mild, moderate, or severe, and urosepsis, with sepsis, and severe sepsis. According to the risk, divided to the complicated or uncomplicated and community-acquired hospital and healthcare professionals associated. It is an isolated infection of the bladder and lower urinary tract without symptoms of upper tract or systemic infection. UTI complicated in pregnancy, immunocompromised patients, renal failure, renal transplantation, anatomical urinary tract abnormalities, as urine obstruction and urine retention, previous antibiotic exposure, and the catheter. And some facts about the catheters. The insertion release many factors. For example, the main one is the fibrinogen, which code the catheter surgery. In such conditions, the members of the therapeutic and stability forming families are mostly welcome. And going next to the literature, around the 9% of all antibiotics prescriptions in the United States are written for the treatment of urinary tract infections. UTI are the forefront of our antibiotic resistance problem. Traditionally, we use the broad spectrum antibiotics, which the drug of choice to both as a community and hospital associated with urinary tract. However, the broad spectrum antibiotics bring us a real problem. Uh, as we continue emergence of antibiotic resistance, coupled with our increasing appreciation for the role of commensal members of the host microbiota, we have undiscovered the urgent need for antibiotic-sparing therapeutics that can selectively treat urinary tract infections without altering the gut and vaginal microbiota. And the gastrointestinal tract, antibiotic consumption increases inflammation. It undercuts the host immune environment and promotes the proliferation of Escherichia coli by increasing the nitrate availability. So that's paradoxically the antibiotics used to treat UTI are also the risk factors for recurrent UTIs, and probably because they affect on the gut and the vaginal microbiota. And the reasons for the multi-drug resistance pathogens, so the increase of antibiotic resistance and appearance of multi-drug resistant MDR pathogens in the course of UTI are related to the high rates of inadequate antibiotic empirical therapies, which is prescribed without the antibiotics susceptibility testing, and finally the results is an ineffective UTI treatment. Risk, according to the developers, regarding UTI hospitalization, urinary disturbance, age, and the prior use of antibiotics. Nice meta-analysis continuing to analyze 25 studies showed us that previous antibiotic treatment applied from even 2 up to 365 days of whole year earlier was the most commonly identified risk factor. Second, and showed among around 20,000 patients from around 900 euros per unit from 70 different countries that 56 of the patients hospitalized were treated with antibiotics. 46 received prophylactic, 26 of them had antibiotics prescribed for the microbiologically proven UTI, 20 for suspected UTI, 7 for the other infections. And the broad spectrum antibiotics used were in majority was fluoroquinolones, 35%, cephalosporins, and penicillins. Check showed the correlation in 2014 between the increased use of broad spectrum antibiotics and increased antimicrobial resistance and multi-resistance to bacteria. And this is the whole family. Klebsiella pneumonia is responsible for around 7% of UTI, but there was 5%. And then we also have the fungus Candida albicans, and one of the most important, which show the drug resistance as Enterococcus faecalis. 7% is resistant to vancomycin. In Poland, is mostly used in intensive care units, and it becomes a real problem for us. So it's this. I hope you see the main problems. Then it's Staphylococcus aureus. It's less than 30% of all UTIs. However, it's more likely to progress to bacteremia and sepsis. And this is the major cause of UTIs in pregnancy. As we know, the pregnancy is connected to the higher risk with stone composition, and catheterization is the most important factor for methicillin resistance in Staphylococcus aureus. As a Proteus mirabilis, which is also the gram-negative bacteria, the common constituent of the catheterized UTI is community in chronic catheterized patients. And Proteus mirabilis express high levels of urease, an enzyme that can hydrolyze urea to ammonia, raise the pH level of urine, and facilitate the formation of kidney stones. So be afraid to see the substones and your CT scans. Suspicious that even then we have the sterile urine. Escherichia coli, as I mentioned above, it's around 80% of all UTI. We have those extraintestinal pathogenic Escherichia coli, and the intestinal Escherichia coli enters the urinary tract system, colonize the periureteral and vaginal areas of the urethra, and provide the bacteria reach the bladder, and it's attached to the surface epithelium of pretrial and long-pretrial antigen. How to treat? The first line for a complicated cystis is intraparenteral vancomycin. Then previously methotrexate right now is not indicated as an empirical treatment due to the high prevalence of resistance and can be considered only for patients with a low prevalence of resistance to astrology. So think about the risk for the recurrence and think about the risk of multi-drug resistance. Fluoroquinolones, cytotoxin, and Poland is a great problem because we are always prescribing cytotoxin as the first line, and it should be considered only as an alternative, not as the first line antibiotic in the treatment of uncomplicated cystis. Ciprofloxacin could be used as a second line empiric therapy in case of a mild, moderate pyelonephritis or complicated UTI treatment as a third line, and this is amoxicillin carbonic acid recommended first line therapy for mild or moderate pyelonephritis, or complicated UTI as well as disease. And then for complicated UTI, with the high fever, sepsis, vomiting, or severe pyelonephritis, amoxicillin combined with gentamicin for second generation cephalosporin and aminic glucosides are recommended as a first line therapy on the line of empiric, and the third generation of cephalosporin applied intravenously as alternative empiric therapy. However, remember that the choice of the antimicrobials for the treatment of UTI should be also based on the local resistance profile. So we did not take all the guidelines and put it into our hospital. We found our local resistance practice. That needs to be very important. We have four types of resistance. ESD our enzymes that control resistance to beta-lactamase antibiotics. AMC enzymes are inducible and can be expressed at a high level by mutation. And PNL registration confers resistance to broad spectrum cephalosporin, acetotaxin, cefalodin, or ceftriaxone. Chemo resistance occurring in the region. This is the resistance to chemo frequently results in elevation to the genes here A, here B, which code durase enzyme and that catalyze DNA supercode. And we have a type of chemo resistance, the genes responsible for the resistance to fluorocheminoids for coding the DNR genes like DNR A, DNR B, DNR C, and they induce the antibiotic resistance by inhibition of writing for phenols, PDA, PRAS, and topoisomerase enzymes. Here, the types of resistance to fosfomycin. The first is based on the decreased uptake of fosfomycin by the bacteria cells due to the mutations in the unit include the glycerol 3-phosphatase transporter, and it was revealed in 1957 in the kernel nuclear. Second mechanism is based on point mutations in the binding site of the EBP glucose phenolphosphorylate transferase, which is developed by Keene in 1996, and the third mechanism of resistance is related to the activation of phosphoryl by enzymatic cleavage of the oxygenated antibiotic or by phosphorylation of the phosphonate group. And resistance to butyrophosphate did not evolve as fast as with other drugs because of its continuous acts as multiple targets in the bacterial cell. However, it is all very good antibiotic to treat cystitis, but the concentration in upper tract, upper urinary tract is so low that it's not suitable to try it. And resistant rates, as I mentioned, required is about 12% phosphorymycin, 2-methoxyl was 1460. However, geographic and age-related difference, rural equivalents from 20 up to 60, and the increasing convergence of coli resistant as reported worldwide in a repeater. Amoxicillin carbonic acid from 3 to 83% of resistant rate. Cefuroxime 5 to 17, third generation cephalosporin, for example, cefalodin 14 to 87%, gentamicin around 1 for patients, and 4%. However, as I speak the times, the resistance rate should be based on the local resistance programs. And the resistance to one drug also can be associated with the drug resistance. And one of the biggest problems, because if we lack in and our treatments not successful, we can go for carbapenems. However, we are observing the resistance to carbapenems and recommended for the treatment of the having complicated pyelonephritis, complicated UTI, and urosepsis. However, the risk factors developed by the European Treatment Center of Disease Prevention and Control. Stay in hospital in foregoing 12 months, dialysis dependence or chemotherapy in foregoing 12 months, previous colonization and epidemiological connection to the carbapenem-resistant uh, colonized patient. So if we know that we're in the same room, we have a patient with CRE, we need to isolate those two patients. Age, diabetes, ICU stay, invasive procedure, treatment with cephalosporin, fluor, carbapenem, also those factors. And the main carbapenem enzymes are OXA48, oxalates, ATC2, ATC3, and DIN1. And right now, Midori number one, Midori metal beta acrylates. Solution, depending on the literature, the combination of two carbapenems could be a solution. But for how long is just a question. For sure it will come. We will just speculate. Antibiotic prophylaxis infectious complications can occur even in sterile urine culture prior to treatment. The epidemic shown is that between a culture mixed in urine and urine from the renal pelvis or stone culture is a non-issue, so we need to perform the renal pelvis urine culture during our endoscopy procedure, and if it's possible to collect some stone fragment and also make the stone culture, it could be really helpful for us to cure our patient. Antibiotic prophylaxis, we need to remember that all endoscopic procedures are substituted towards UTI post-endoscopy procedure is reported in around 10%. When we shall use when we have a urological malformation, a previous history of UTI, and a particular recurrent case. How to use, we have several guidelines in the topic of several gentamicin and amoxicillin, carbonic acid, or gentamicin. Right now, it's recommended to grow urological malformation for previous history of UTI. However, in example, antibiotic prophylaxis before epidural and sterile delivery, and the systemic review and meta-analysis is performed by the levels. At all, in conclusion, we think that antibiotic prophylaxis in ESD with sterile delivery give us no benefits, so we should avoid doing the antibiotic prophylaxis instead. Where's the way to go? For sure, educate healthcare professionals of the suitability of urine culture. We shall read the features, we shall read the meta-analysis, reviews, like as I showed you before, and compare it to our local centers. We also with cooperation with the companies, rapid knowledge process that could shorten the waiting time for urine culture. Developing antibiotics, this is the way to go. However, remember that, as I mentioned, antibiotics control in the future we have also the probiotics and antibiotics for therapeutics, including, for example, small molecular inhibitors and bacterial inhibitors. Immunomodulatory therapy that alters the host response to infection, as I told you that taking the breath, taking the virus, increasing the inflammation, and vaccination against microbial therapies. In conclusion, pre-interventional urine culture is mandatory. And antibiotic therapy is important in the UTI treatment, but in recent years it's becoming more challenging due to the increasing resistance of UTIs to the applied antibiotics. So speak with the GPs locally, put this topic to be more and more worldwide. The use of an internal urine culture and stone culture was recommended to adapt the antibiotic therapy in case of post-operative infection complications. So whenever you're in urinary or police, take urine sample and do it every time. Current findings in the literature support the EU and EUL and EU guidelines that the single dose antibiotic is sufficient for low risk PNL and urine neuroplasticity that will allow antibiotics to prophylaxis. Stay with the contact, close contact with your microbiologist, dermatologist. Stay up to date with literature, count the resistant rate, and treat your UTI according to the up to diagram. Thank you for your